Dear Chairman and colleagues, thanks you again for this opportunity. I recorded the presentation with my comments, and if you're okay with that, we can discuss any question after. Just a brief introduction. It is, I would say, a simple and cheap tool for bedside use, far away from the beautiful and more complex tests shown on the oncologic session this morning, but here it is.
Good afternoon, ladies and gentlemen. I would like to thank the scientific committee for this opportunity, and I'm going to submit this work on behalf of Professor DELPERO. Today I will talk about the development of a simple tool to exclude pancreatic fistula after pancreatoduodenectomy in every patient using the neutrophil-to-lymphocyte ratio. In one hand, it is commonplace to say that pancreatic surgery is an highly morbid surgery dominated by pancreatic fistula and associated life-threatening complications. A lot of scores to predict the occurrence of pancreatic fistula has been published without any consensus to date. In second step, after risk stratification, a postoperative selective drain management is discussed. However, everyday practice is sometimes far from the theory, as recent studies highlighted that only few surgeons, namely 13 to 27%, follow the recommendation for drain removal at postoperative day 3 in Korea and USA, regardless of the risk score. One of the reasons for the low acceptance is the large discrepancy between guidelines and traditional experience-based management. So, maybe there is still a room for improvement in pancreatic fistula prediction. On the other hand, the neutrophil-to-lymphocyte ratio has recently emerged as an attractive alternative for characterizing the body's inflammatory status as other biological ratios associated with monocytes or platelets. The NLR is frequently included in predictive models as a prognostic marker of various cancers. And furthermore, based on the relationship between the inflammatory response and postoperative complications, some publications have focused on the NLR and demonstrated it to be a valuable predictor of postoperative complications after various surgeries, for example in thoracic or colorectal surgery. So the question of this study was the following. Is a simple biochemical parameter useful to exclude a diagnosis of clinically relevant pancreatic fistula in the early postoperative course after pancreatoduodenectomy? To answer to this question, here we go with a flowchart of the study. The cohort for the model development included 451 patients who underwent pancreatoduodenectomy between 2012 and 2020 in a comprehensive cancer center, the Paul-Calmette Institute in France. The set of 451 patients was randomly divided using a ratio of 2:1 into the training cohort, 301 patients, and the validation cohort, 150 patients. Early postoperative course was defined as less than or equal to postoperative day 3, and the relationship between simple biochemical parameters was tested to exclude the occurrence of clinically relevant pancreatic fistula. Then surrogate markers were tested in the validation cohort, and the external validation cohort included 197 patients who underwent PD at another academic center between 2018 and 2020. Just a word about the definition of pancreatic fistula. Obviously, the 2016 definition was used, and you can see the clinical change associated with pancreatic fistula. Clinically relevant pancreatic fistula included grade B and grade C. About the result, in the whole cohort of 648 patients, pancreatic fistula occurred in 21% of the patients, divided in grade B for 15% and grade C for 5%. Here are the main postoperative complications with delayed gastric emptying, hemorrhage, and about the mortality. The in-hospital mortality was 2.9%, and obviously the 90-day mortality was slightly higher with 4.1%. About the baseline characteristic of the study population, usual factors are associated with pancreatic fistula as male sex, BMI, and pathology subtypes. About the surgical characteristic, again, same factor as usual, as the absence of neoadjuvant treatment, a soft pancreatic parenchyma, and a small pancreatic duct, namely under 3 mm. As you can see, concerning the biochemical parameters, namely leukocyte, neutrophil, lymphocyte, and NLR ratio, there is a difference in every single parameters but lymphocyte at postoperative day 1 between patients with and without pancreatic fistula. So every biochemical parameters change with the occurrence of pancreatic fistula. Now we are only considering the training cohort. Here are the biochemical parameters and the associated base cutoff to exclude pancreatic fistula occurrence. We have chosen the NLR value at postoperative day 3 for the rest of the analysis, considering the neutrophil and lymphocyte size of immunity, both of which were significantly different with pancreatic fistula. Again, in the training cohort, here are the factors associated with the absence of pancreatic fistula in univariate and then multivariate analysis. Of note, you have to notice that the study was conducted to exclude the pancreatic fistula, which gives sense to the odd ratio. As every training cohort, the references are easier to make, considering the overlying bias. Then we challenge the NLR in the internal validation cohort, and it stayed statistically significant. Last but not least, same challenge in the external validation cohort and same conclusion, it stayed statistically significant in multivariate analysis adjusted for sex, BMI, soft pancreatic texture, and the pancreatic duct size. Here is the receiver operating characteristic curve used to determine the best cutoff of the NLR at postoperative day 3. A lot of numbers, but one could ask, what does it mean really? To understand the characteristic of the test, you have to understand that the meaning was to exclude the clinically relevant pancreatic fistula under a cutoff value of the NLR. So it's quite the contrary of usual perception of a test. The positivity of the test is a value of NLR under 8.5, and the event is the absence of clinically relevant pancreatic fistula. So in this situation, we can determine that first, NLR is a quite accurate test with a good area under the curve. The specificity is high, meaning that 84% of the patient with a clinically relevant pancreatic fistula had an NLR above the cutoff. And more importantly, the predictive positive value here means that if we have a positive test under the cutoff, what is the probability to have the event absence of clinically relevant pancreatic fistula? So here, it is 93%. In 93% of the case, you can exclude the event of a clinically relevant pancreatic fistula. On the contrary, with an NLR above 8.5, 38% of the patient have a clinically relevant pancreatic fistula, which means it is a gray area. You cannot conclude about the outcomes of the patient. About the outcomes, as you can see, there is a significant difference in patient outcomes according to the NLR under or above the cutoff. For pancreatic fistula, obviously, as it was designed for, but also for hemorrhage and postoperative mortality. Finally, what to keep in mind? With an NLR under 8.5 at postoperative day 3, you have a very low risk of clinically relevant pancreatic fistula and associated mortality. It is early, objective, and independent from surgeon subjectivity, mitigation strategy chosen, and inadequate drainage, which makes NLR a good bedside marker for data-driven selective drain management. Thank you for your attention. I am at your disposal for any question.
Thank you very much, Jean-Jean. Any questions from the audience? Well, first of all, this is a very nice study, and congratulations for this. I would just wanted to ask you one question. You show here that the positive predictive value of your study is very good. But you say also in the conclusions that if the ratio is below 8.5, the risk of having a clinically relevant fistula is low. You've shown this a sensitivity of 60%. This means that this is only valid for 60% of the patients. You have 40% chance of error if it is below 8.5, correct?
I twist the statistic in the other way because the meaning was to exclude. So here the sensibility, it's the proportion of patients with pancreatic fistula who had a positive test. So we cannot trust on the sensitivity on this picture. And that's why I explained that I prefer to focus on the specificity. And it's quite the contrary as other tests when you want to put the focus on the prediction of the appearance of an event. That's, but yes, it's not 0 or 100%. So there is some mistakes in the prediction.
Any other questions? Okay, so we move on. Thank you very much.